Hi guys, I wanted to record this quick video to provide a little more information and give you all a heads up about what it is going to look like to be putting in PICC lines here at Chalk It Mission, something that we hope to do more of in the future. I just finished up about a month and a half of training with the PICC team up there. So I'm really excited to get to do more of these lines down here and make it an available resource for our patients and families. And hopefully it can be helpful for the team and the families, and it can be a good resource going forward. So I wanted to give a quick rundown of the procedure, just so if you're not familiar with what the PICC line placement looks like, you can have kind of a general framework for what to expect, and then a couple of details about how you as the nurse that's helping during the procedure can just mentally prepare and know what is coming down the pipeline. So ideally, we will have about 24 hours notice before one of these lines is going in. So whether the kiddos in peds or PICU, I will try to meet them, as soon as we hear about the need for the line, and then go through the procedure with the patient and or the parent, get informed consent, and then assess the patient's extremities, determine what kind of vascular access they have, and make a tentative plan for which vessel I'm going to attempt. And then that way everything is kind of set up for the following day when we do the procedure. We're going to attempt to do these procedures in the second half of day shift. It won't always happen that way, but given that I am usually night shift and things are a little bit crazier and not as many consistent resources at nighttime, we're going to try to plan these for sometime between 4 and 6 in the afternoon on day shift, as much as we can. There will be exceptions, but so then when it is time to do the procedure, again, I'll start with just a quick assessment, make sure everything looks the same. I'll measure from the point that I'm going to access the vessel up until the distal SVC. That gives me a measurement for how long I'm going to cut the catheter. And then I will go ahead and get sterile. So the whole procedure is sterile. So anyone in the room needs to have on a hat, and then whichever nurse is helping as my sterile assistant will need to get fully sterile. So gown, gloves, and then the hat. For the first 15 to 20 minutes, I'm going to be getting sterile myself and then setting up my tray with all of my supplies. I shouldn't need any assistance during that time. And it does take around 15 to 20 minutes. So if there are other things that you as the nurse need to get done in that amount of time, you can come and go, and then just kind of plan on being back, around 15 to 20 minutes after I start that tray set up. At that point, once we actually start the procedure, the first thing that the nurse is going to help me with is holding the patient's arm. So I'm going to be scrubbing with CHG, and so I just need help with a non-sterile hand to hold it, kind of elevate it so that I can do the scrub and make sure everything is sterile. And then once the extremity is sterile, I'll lay out the sterile towels and then wrap the wrist in a blue sterile towel, and take it from the nurse. And then the sterile field will be established. The nurse will go ahead and get sterile, and then come back and step into the assistant role, which is primarily just helping to hold the arm and keep it steady. So a quick tangent on sedation. Normally with bigger kids, like 5 and above, we don't necessarily need sedation. Obviously that'll be something for me to discuss either with the PICU doc or the hospitalist about the patient and what we think our plan should be, and that should happen in that 24 hours before. So if it's a bigger kid who we think will be fine with just local anesthetic, then there won't be any need for PRNs, but sometimes we'll give them a PRN, Ativan, or morphine prior to starting the procedure. But otherwise, your job during the procedure is just to hold the arm. And there are a couple little tricks and preferences that I will tell you about in the moment. I don't want you to stress about it. It's not something you need to practice, I can easily show you just how it helps to have the arm aligned. And we can work on that together while we're in the procedure. There was something I wanted to mention about the hold, and I'm forgetting, so hopefully it will come back to me. But in terms of the actual procedure, it's just like placing an ultrasound guided IV. So after cleaning the arm, then the first step is to use the J-tip to just give them a little bit of lidocaine anesthesia. And then I will access the vessel with a needle. And then once I'm in the vessel and I've confirmed that with ultrasound and blood return, then I will go ahead and take the needle out and thread the guide wire. And then once the guide wire is in, I use a little plastic dilator device to make the vessel a little more patent. And sometimes that's uncomfortable for the patient. And sometimes we have to make a little bit of an adjustment to the position during that time to make it go through. Once the dilator is in, then I remove that guide wire, and then while the dilator is holding the vessel open, I go ahead and place the PICC line, the catheter. At that point, the only things remaining are to take an x-ray and verify placement that the distal tip of the PICC line is in the distal SVC. That's kind of our goal. And then once placement is confirmed, I will do the PICC line dressing. And the whole thing ideally takes about an hour, about 20 minutes for me to set up my tray, about 20 minutes for me to actually place the line, during which time you're like actively helping, and then 20 minutes for x-ray and dressing. That isn't an ideal situation. There's always opportunities for excitement, and usually it comes in the threading of the guide wire and taking x-ray. So sometimes the catheter can go up and towards the neck. That was what I was going to tell you. While I'm threading the guide wire, if I meet any resistance, another thing that you can help me do is get their patient's head to turn to whichever side I'm working and down. So if I'm working on the right side, we would have their head turn to the right and point down, and same with if I'm on the left. And that just helps because it creates like a 90-degree angle so that the catheter has to go across the chest instead of accidentally going up into one of the veins in the neck. So sometimes if there's gonna be extra time added, it's usually towards the end of the procedure. If something's not threading right, or if we take the x-ray and it's not in the right place, then we have to withdraw the catheter and do some power flushing and adjusting of the arm and try to get it into the right position. All of those things I will talk you through during real time, so I don't want you to be stressed out about it, but there's just a little bit of minutia that comes with making sure it's in the right place. I'm gonna look at my notes quickly and just make sure I'm not missing anything. Oh yeah, the documentation that needs to happen. So there's two things. The clip form, I guess, is now in Epic, so that will need to be documented by the nurse after the procedure. And then this PICC line form, which you probably have seen, it will stay at the head of the bed of the patient after they have the line placed. So we can work on this together. There's a lot of details about how long the catheter is, how much of the catheter is outside of the patient, and like some specifics about the lot number of the catheter and things like that. So I'll help you get all these forms filled out, but we need to make sure we do that. And then in terms of just at the very beginning, we're working on setting up a PICC cart, so I will have everything I need in terms of supplies, but I do need you to grab 2 J-tips, and then, as I was mentioning, any PRN medications that we decide to give the patient, I'll have you draw those up as well. I will try twice, and if I'm unsuccessful, then the kiddo will have to be scheduled with IR as a backup option. And I think that is about it. So please flag me down if you have any questions. I am obviously going out on maternity leave shortly. I am hoping to do another line before baby comes. So it's going to involve a little bit of coordinating because I'm not going to be doing night shifts regularly for the next month, but I'm hoping to just be available kind of on an on-call basis if you have any kiddos that need a PICC line. So hopefully we can work together and do at least one in the next month or so. And if not, then we will be ready to go in October or November whenever I'm back from maternity leave. So thank you all for watching and for your help. I definitely couldn't do it without you. And please always give me feedback and communicate about any questions or things that you think could go better or go differently next time. I want to hear from you guys. So thanks so much.